Chapter 18, Eating and Feeding Disorders. Um, Basically, we start with just a little case study talking about a client. Well, you're going to notice later on in the discussion about having a diagnosis of anorexia. So we will talk more about the case study in class. So basically, this is a clinical picture of a 15-year-old that was having issues with anorexia nervosa, was being examined by the school nurse. So again, so we're going to talk about the clinical picture of anorexia, bulimia, nervosa, and binge eating disorders. Anorexia, again, these clients, they pretty much present with a fear. They have a fear of gaining weight, rather. Also, they have a significant difference in their perception of how food tastes. Their appetite kind of decreases. Usually, these unique, unpleasant sensations help to perpetuate the disorder, which leads to restriction and sometimes purging. And purging is basically, we'll talk about that too a little bit later on. They just eat and then they'll make themselves throw up. Okay, so they vomit um, when they do purge. Okay. As far as diagnosing these clients, you remember we talked about the DSM-5 criteria. So this criteria must be met. So they have restricting energy intake below the requirement that they need. They have a significant weight loss. They become malnourished. They also have feel like I said, a fear of gaining weight, um, body image disturbance, and also again, they self-evaluate themselves all the time. Like they complain of being overweight and how they're tremendously underweight and they're malnourished. Again, restricting type. These symptoms must occur or must be. I'm sorry, it must last over 3 months when we're looking at the criteria. So during the 3 months with these clients, or the past 3 months, there's a history, and then the criteria is used. So like I said, for the prior 3 months, for a 3 month period, I'm rather. They have again they may binge eat, they may purge, like I said, during the past 3 months. So it's nothing diagnosed within 2 weeks or 3 weeks. So it has to be over 3 month time period. Okay. Usually with these clients, they also have other comorbidities, things like OCD, depression, anxiety, bipolar, PTSD. They could be, substance or alcohol abusers as well. It could be genetically linked. It could be related to neurotransmitters, neurobiological or deficit in your neurotransmitters. Also could be related to some environmental factors. Environmental factors, again, could be dependent on these clients. There, could be social media, videos that they watch, things of that sort. Um, so as far as our assessment, again, we want to do a thorough assessment on the client, getting a history. How are they purging? What method do they use to control their weight? Again, also talk about their interpersonal, social functioning skills. Then, of course, a mental evaluation should be done on these clients as well. Not only are we looking at mental status, we're also looking at the physiological status as well, parameters. Again, the assessment guidelines, we want to make sure we do our vital signs, do a system review, looking at the appearance of the skin. Again, like I said, these clients could be suicidal, nutritional deficit, and fluid and electrolytes or fluid intake, which could lead to dehydration. We're also going to be looking at our lab values. Again, looking at if they're hypomagnesemia, hypokalemia, kalemic hypophosphatemia. They also could have a thiamine deficit. Um, so again, during the assessment, this client says that this all started because my mom found out I was fainting. I fainted during a gym class. It's ridiculous. She seemed genuinely unaware of how her weight and other symptoms may be a source of their alarm. Why is that mom alarmed? Because the client has lost weight, then she fainted at school. So again, her skin is yellow. She showed signs of dehydration. So again, with that in mind, when we further assess these clients, these are some questions that the school nurse may ask the client as well. So we'll discuss those later as well. And with the discoloration in the skin with anorexia, it could be linked to what do you think? What do you think the answer is going to be? Like I said, we'll talk about that. As far as our nurses' diagnoses, these are all not all inclusive, but as you can see here, As I talked about becoming malnourished, these clients may have electrolyte fluid balance deficit. So again, we're going to make sure we treat those physiological problems, which would be more critical, life-threatening, and then we'll also, deal with the mental issues if there are any. But we're gonna have to get these clients medically stable initially. Our goal again to make sure that these clients improve their nutritional status, get their cardiac output within normal limits. Again, make sure that they have a positive outlook, positive body image um, perception. And then also planning, during our planning phase, these clients go through the refeeding syndrome. They may go through refeeding syndrome, which is a severely malnourished complication that you will see is potentially lethal. The complication may result in, like I said, a fluid balance and glucose metabolism, as well as the phosphate level may be low, magnesium level could be low, and then again the potassium level. And then, like I said earlier, they may have a thiamine deficit. Nutrients with these clients, they are reintroduced very slowly to avoid these syndromes. So you don't want to go ahead and just push nutrients in these clients because it can further complicate. So we introduce nutrients to these clients, but they are introduced very, very slowly to prevent them from developing refeeding syndrome. Again, once that client is stable, then we are going to address the underlying cause of the disorder. So we're going to do, is it related to stress? Is it related to alcohol? So you're going to get them medically stable first. Okay, this is another audience question. Of course, here are interventions based on our assessment. If the client may be suicidal, may be our priority, but then again, it may be a physiological issue that may be a priority as well. These clients could benefit from some treatments, from some pharmacological treatments. Again, um, which could consist of some your SSRIs if they may be on an antidepressant or one of your second generation antipsychotics, or maybe they may be on a mood stabilizer, or maybe some integrative medicine like yogurt, massages, acupuncture, bright light therapy. Then again, these are some of your psychological therapies that they may also benefit from. This is a good care plan on page 337, and we'll discuss that in class. Again, instead of doing the lecture, I'm recording it, so we're going to be going through some case studies, and I'm bringing your attention to the case study on page 337 and a nursing care plan. The next disorder I want to talk about is bulimia, which is where you would see a recurrent episodes of binge eating. With these clients, they again, they may they are assessed too over a 3 month period as well. Uh, so again, it's just like anorexia. We look at the data, we do the assessment, and it has to occur over a 3 month period. They also may have some comorbidities, things like depression, anxiety, bipolar, alcohol, and substance PTSD. Also, they may have borderline personalities as well. Uh, Risk factors, it could be genetic also. It could also be due to neurotransmitters, deficit. Um, I'm sorry, they may have an increase in their serotonin, like in their dopamine levels, which is a part of the brain, your neurotransmitters. So then when there's an increase in dopamine and increase in the serotonin, it could cause an increase in sensitivity and motivation. So it speeds them up, make them very hyperactive. So again, due to that, those deficits there. It could be environmental factors as well. Um, and usually when environmental, it could be like going back to trauma, childhood trauma, things that happened early on. Also could be related to their eating habits when they were younger as well. So of course we want to look at lab values. The same nursing diagnosis may apply as well as we saw with anorexia, cardiac output impaired, electrolytes, disturbed body image. They could be at risk for powerlessness, low self-esteem, and then also social isolation. So again, we want to initially we got to make sure they're medically stable, getting their cardiac output increase, um, also getting the electrolytes back in balance. And then again, talk to the client about coping, get an assistant also, and also so referring them to support groups will be also part of our planning. Um, these clients basically, like I said, if they are medically critically unstable, they're going to have to be treated in an inpatient facility. Um, they also may benefit from some psychotherapy. As far as some other treatment modalities, pharmacology, they benefit from antidepressants. Um, Also, these are some other advanced practice interventions: cognitive-based therapy, family therapy, interpersonal therapy as well. Binge eating, basically, this is where clients eat. They have recurrent episodes of binge eating. They eat anywhere from 1,500 to 5,000 calories within a 2 hour period. And then what they do is they don't like to eat in a crowd. They feel like they can't stop eating or control what they're eating, so they get embarrassed. Okay, they get embarrassed. So they also but using the same criteria, the time frame rather, but over 3 month period with these clients with binge eating, they eat much more rapidly than normal. Like I said, they eat until they uncomfortably get full. That large amount when they not feeling physically hungry, they just eat, eat, eat. And like I said, they like to eat alone because they're embarrassed. They disgusted about how they eat. Also, you may see some other comorbidities. These clients with binges, they may also have some specific phobias. Like I said, they don't like to eat in a crowd, social phobia, PTSD, and they also may be alcohol and chemical or substance abusers as well. Binge eating is genetic, also could be also due to some neurobiological factors, cognitive factors, environmental factors as well. We want to assess this client, their perception. Okay, we don't, how do they perceive themselves? Vital signs. Again, you want to do your system assessment, getting a psychological history, psychosocial, their nutritional patterns. We have to, have them to keep a diary. History of their weight cycle could be up and down. Okay. Uh, as you can see here, the diagnoses are the same. Um, our outcomes, we want these clients, their nutritional status to meet their metabolic needs. Remember, I told you they're hyperactive, increasing in their motivation. So we want to get their make sure they get enough nutrients or calories to meet their metabolic need. Uh, uh, we want them to be satisfied with their appearance, be able to cope with, effective coping mechanism, reduce any anxiety as well. So as we plan our care, we implement, we have to provide that care being non-judgmental, helping the client keep a track of what triggers them that episode, what triggers it. So again, we want to help them to identify the positive coping mechanism. These clients may benefit from some SSRIs and SNRIs as well as we treat these clients. So they may be on a similar lisdextrostate for tamine. I'm sorry, it's the same thing as Vyvanase. It's a stimulant needed. It's used to treat those clients with ADHD. It's FDA approved to treat those clients with mild to moderate binge eating disorder. They're used for adults clients rather. Okay. In adults with binge eating disorder, the most common side effects that you would see with these clients on this medication, may have dry mouth, insomnia, decrease in appetite, increase in heart rate. They feel jittery. They feel like they have an anxiety attack. There is also a black box warning on this drug due to the concerns about abuse and dependence as well. Like I said, it is a stimulant to treat those kinds of attention deficits. These clients may also be candidates for bariatric surgery. Also, then some other psychosocial therapies as well. Pica, I'm sure y'all have heard of pica. These clients, they may eat non-item food items. Things I've known a friend of mine ate tissue. They may eat dirt. Also, so this is they have a craving for that. Rumination. This is where these clients they regurgitate they re-chew their food, they re-swallow it, or they spit it out. So there's no medical or mental reason for this behavior. So usually with feeding disorder, like I said earlier, it may start in childhood, where children may be picky. Sometimes it resolve on their own, and sometimes it doesn't. And also, you may see it with the clients with, I'm sorry, they have low BMIs again.